Okay, so good afternoon, and thank you so much for joining this session. My name is Behdad Tahayori. I'm the lead person for this study. I'm accompanied by Dr. Michelle Prez and Dr. Julia on the study. The title is The Effect of Reticulospinal Tract Stimulation on the Spinal Pathways. There are some terminologies that I might not explain the details, but if you want to know the details of those explanations, you can put it in the chat and I will address. We start from the reticular formation, and that's our interest. There is evidence to show that the nucleus caudalis pontis, which is the lowest nucleus in the actually brain stem, and after that is the spinal cord. This nucleus has been shown to be involved in generation of startle reflex, and is one of the most important nuclei that generates and contributes in the motor planning of the reticular formation. On the other hand, we also know that the H-reflex can be facilitated by a preceding startle reflex. The way we do it in laboratories is through a method called auditory startle reflex, that we give subjects a huge beep for like 30 milliseconds. This, again, evidence shows that this activates the nucleus caudalis pontis. Now, reticular formation has recently been subject of extensive studies because of its role in spasticity and motor impairment in patients with upper motor neuron lesion. But there are inconclusive results related to how RCT affects the inhibitory spinal mechanisms. This is the current hypothesis and the model that has been suggested. There are contrasting results about the effect of RCT damage on spasticity, because on animal models, actually, overactivation of RCT is related with improved function. In human, overactivity of RCT is accompanied by actually impaired function. So there are two contrasting things. This is a current theory that explains possibly why does that happen. But what you can see in this model, they have largely disregarded inhibitory pathways in the spinal cord. So the idea is that about bidirectional connections to different parts of the reticular formation, and that's why you see different effects in human and in animal. But what we think is that the inhibitory mechanisms in the spinal cord of human are different. So our goal was to make do some experiments, examine how reticulospinal tract affects inhibitory mechanisms and inhibitory interneurons in the spinal cord. We are at the first stage. We are doing it on healthy individuals, and we will hope we soon get some data from patients. So that's our goal. Our goal was to examine the role of RCT on inhibitory mechanisms. And to do that, we elicited soleus H-reflex, that is a very common reflex for all lower extremity. We also conditioned the H-reflex by a type of inhibition called D2 inhibition. Very briefly and quickly speaking, D2 inhibition is a presynaptic mechanism initiated by stimulating the common peroneal nerve, so tibialis anterior and its connection to the soleus, but it is not a reciprocal inhibition. This is D2 inhibition and is presynaptically mediated. We also designed an auditory stimulation, and we applied that auditory stimulation either prior to the H-reflex or prior to this D2 inhibition. This is a quick show of our setup. This is our glass stimulator, and the EMG unit at the bottom. This is the custom-made auditory stimulation. because you need to go high on intensity, and the ordinary ones would not allow going to above 90 decibel that we needed. This part that you see is the module that I used to synchronize the auditory stimulation with electrical stimulation. This is the software that I designed to capture the data and show the data in real time, a view of our setup. And I do have a video. I will show that to you in a moment. So this is our study design, and I show a quick illustration scheme of the pathways. So the pathway we are activating is this soleus H-reflex, and this one that comes from the TH through interneurons. But we are interested to activate the reticular formation and see how the reticular formation would affect these interneurons. Basically, how it would interact with D2 inhibition here, how it would interact with the soleus H-reflex. To do that, we designed 5 protocols that conducted on the same subject, each of the subjects. H-reflex, that serves as the control H-reflex. Then H-reflex being conditioned by a common peroneal nerve stimulation at long intervals, at about 200 millisecond interval. This causes a long latency depression called D2. Then our next setup, our next protocol was to facilitate or condition H-reflex by a preceding auditory stimulation. And then we did 2 different things. We facilitated the H-reflex by auditory stimulation, but prior to that, we conditioned the H-reflex by common peroneal nerve stimulation. And the 5th protocol was that condition the CP stimulation by a preceding auditory stimulation to see the effect on the H-reflex. And I will explain in a moment that we expect this one would facilitate the inhibition. This condition would inhibit or would decrease the amount of inhibition or inhibit the inhibition. Some sample data, as you can see here. This is electrical stimulation. This is H-reflex, the one that we are looking for. This is muscle response. So this is a control condition. This is common peroneal nerve stimulation prior, 200 millisecond prior to the H-reflex. And as you can see here, we were expecting this one. It reduces the amount of H-reflex, as can be seen here. This is our auditory stimulation in the middle. And as you can see, the auditory stimulation has released the inhibition in the H-reflex. And again, this is a sample. I will show you in a moment our average results. Sometimes you get auditory responses. So this is a muscle twitch. This is startle reflex, but it gets inhibited very fast. Like for the first few trials, we might get this muscular response, but the subjects get used to it. What we see and what is reliable is to measure the H-reflex. I show you quickly a video of what we did. If I can run the video. Does it? I think that my best bet is to do this one. So that is our oscilloscope. You see the H-reflex there in real time. When we stimulate, we get a new H-reflex, the updated H-reflex. And then you see it in the software, and the software makes some measurements in real time. These are all custom designed. And I think I would stop right here so we can continue. And I go back to pointer option, the laser pointer. Now that we don't want it runs. So, okay, so basically this is our research setup. Slide. So other results, and I try to explain what happened here. First of all, the blue bars are M waves. These are indicators that we have applied the same amount of electrical current into the nerve. So you want to have equal size M responses. This means that any variation you observe is not because of changing your stimulation strength, and it was a neural effect, not an artifact because of your stimulation. So that M is very critical to monitor. I have normalized my data to control H. So this is unconditioned H-reflex, and we regard it as 100%. As you can see, with controlling the M to the same level, when you condition it with the preceding auditory stimulation, the H-reflex increases to about 118%. So you see a facilitation in the H-reflex. Obviously, when we do common peroneal, the D2 inhibition, you would see that the H-reflex substantially decreases from its normal value. So from 100% to about 60-some%. This part we know so far. These two are the parts that we were interested to examine. So we have CP conditioning, and we have this auditory stimulation prior to CP conditioning. And as you can see, it even further inhibits the H-reflex. So if I compare this one, which is CP only, and this one, which is conditioned by ASR auditory stimulation, you see further inhibition. We assume the ASR has activated the interneuron, most probably the interneuron of the common peroneal. Then we had CP and then ASR stimulation. And as you can see, the ASR decreases the amount of inhibition, meaning that it facilitates the H-reflex. So it goes to the completely opposite direction. And again, we think ASR is either presynaptically or postsynaptically affecting the H-reflex. We do not know. With this experiment, we can't tell if it is presynaptic or if it is postsynaptic, but what we do know is that this part, CP, is presynaptically mediated. Whether ASR directly affecting the motor neurons of tibialis anterior or indirectly affecting the interneurons or both, with our non-invasive experiment, we can't answer that question, but still it is very valuable to compare these results with patient population. The second part, our second experiment, which is right now an ongoing experiment, was to answer one question. Even though we cannot answer if it is presynaptic or postsynaptic, we can still examine to see if there is a linear or non-linear relation in the amount of inhibition at different strengths of common peroneal stimulation. This might be an indirect evidence for presynaptic inhibition. If we see a non-linear, that is most probably more in favor of a presynaptic mechanism. Right now, this is data from just 1%. So the previous one, we have collected data from 24 people. We regarded the first 10 subjects as pilots, And when we felt confident that our method is reliable, we tested 12 or 11 additional subjects. This is the results of the additional of the new 11 subjects after we made sure that we are consistent in our method. This one is just one subject, but we are continuing doing data collection. What we have observed in one subject, so we change the amount of inhibition coming from common peroneal nerve. The way you do that is you increase the stimulation of common peroneal nerve in terms of its motor threshold. We, in our experiment, we had set that stimulation at 1.2 times motor threshold. Here in this new experiment, and that's because of the data we got, we decided to do this part as well. We are changing that 1.2 to 0.5, 0.8, 1.4 in addition to 1.2 and observe the amount of inhibition. So actually what we have observed is in the middle, you see a linear relation, but at the beginning and at the end of the curve, we have observed again opposite directions. And this makes sense because when you're at 0.5 common peroneal nerve, you have no inhibitory effect from common peroneal. It is very low motor threshold. So most probably that ACR was directly affecting the H-reflex and enhancing it. At the very end, because it is substantially above the motor threshold and causing a huge inhibition, you would see less effect on the ASR. We are working on this one, and we think having like maybe 5 subjects examining this relation would give us a better idea. But finally, our goal is to test this one on stroke patients or on patients with any type of spasticity, because as we said, RST has shown to be a very important pathway in the development of a stroke. Now, finally, if we can show that activation of the RST is not always a facilitatory mechanism to increase the H-reflex, you can use it indirectly on the inhibitory mechanisms to actually finally increase the inhibition. That might be a good treatment option. So our next set of experiments on patients would be very interesting and important. We have presented again our partial data. At that time, we didn't have all 12 subjects, we had less, but we presented in the Society of Neuroscience conference. I'm an editor of Frontiers in Neuroscience, and I've actually opened a special topic and special issue on the role of reticulospinal tract. And I would like to publish these data in our special edition. These are other editors of that edition. And finally, I would like to thank the University of St. Augustine for giving us actually two funds. Without those 2 funds, we would have not been able to set up this lab because electrophysiology labs are expensive. And we got an old system. Old doesn't mean doesn't work. We got that electrical stimulation that we purchased was 30 years old, but it was untouched. It was new, and then we purchased other parts. We purchased the software. We purchased MATLAB. Without those funds, we would have not been able to do this experiment. So I would like to thank the university for giving us that fund to make this electrophysiology lab possible. We have some other ongoing projects pending IRB approval, and we as a team, we would like to invite anybody who is interested in these type of studies to join us. If they have ideas that they want to test, we are more than happy to discuss with them, design new studies. So I would like to stop here and open for questions. If there is any question, if there is any part you want me to provide more details, I'm ready. Okay, so yeah, we have 10 minutes, so I would like to thank you. I'm going to stop sharing the screen and getting back to Dr. If a moment. Okay, thank you so much.